UKA. Sorry, forgot to do that. Thank you. So, yeah, so since 2018, the MHRA implemented a pregnancy prevention programme, and that does a couple of things. So first, it bans Valproate as first-line treatment for women and girls of childbearing potential, so not intention, just potential. Second, it mandates that patients who are already receiving Valproate switch to a medication, switch to an alternative, if at all possible. And three, that if patients are to remain on Valproate, they have to use a long-acting reversible contraception, so if unable to switch, and submit to regular pregnancy testing. So this change followed a decision of the European Medicines Agency. They held a big public hearing on Valproate in 2017, namely to discuss how effective efforts to strengthen warnings have been. And so as a result of the 2017 hearing, where there were 28 patients and patient representatives, among other stakeholders, who provided evidence. And the UK, a year later, implemented the pregnancy prevention programme. So I've got here some really recent media coverage. So some of you might have seen it in the Times and Sunday Times. Sean Linton, who's a UK journalist, has been covering this story for subsequent weeks now, since last month. And so he's been covering both the historic treatment of the medication. So you can see here a scandal worse than thalidomide, this historic failure to disclose risk, but also covering the fact that, so you see in the second, the second one, the scandal worse than thalidomide, that we've still got a number of women being prescribed Valproate despite these risks. So why is that drug still being prescribed now? So the historic treatment of Valproate was one of the 3 healthcare interventions examined by the Independent Medicines and Medical Devices Safety Review, also known as the Cumberland Review, that was published in 2020. So it sought to look at Valproate, Primodos, the historic hormonal pregnancy test, and vaginal mesh, and how the healthcare system responded to these interventions and the associated controversies around them. So like the EMA public hearing in 2017, this review engaged a wide range of stakeholders, including patient groups, clinicians, academics, professional and trade bodies, regulators, manufacturers, and public bodies, who provided written evidence, oral evidence, personal testimony. And so the written submissions formed the basis of a document analysis that I conducted, where I sought to examine whether the legitimation afforded to Valproate as a potentially life-saving medication affected any of our understandings of risk and responsibility within the discourse surrounding use in pregnancy. So much like Natalie and Kirsty were saying this morning, that sort of mandate for behaviour change to respond to risk in a certain way, and that managing risk is seen as a tenet of maternal responsibility. So to date, there's been a lack of engagement with Valproate from this sort of sociological perspective, where we look at risk and responsibility in prescribing Valproate. So just briefly, I identified 3 themes in my analysis. So the first was that the discussion that Valproate exposed pregnancies are presented in a sufficiently similar way as other problem pregnancies, so like alcohol exposed pregnancies, like we heard this sort of widespread effort to prevent. So we sort of, we saw this in the way that Valproate exposed pregnancies were talked about as avoidable and preventable. And there's a lot of similarities between the way we talk about alcohol exposed pregnancies, and that sort of, it sets aside the therapeutic benefit that Valproate may have for the potentially or actual pregnant women taking it. And so the discussion of a solution, i.e. prevention through a pregnancy prevention programme, defines it as a problem, that it's a problematic pregnancy. So those who choose to become pregnant on Valproate as an active informed choice are largely missing from that discussion. So that discussion as Valproate exposed pregnancies, as problem pregnancies, hinges on a specific construction of risk and a specific construction of responsibility. So in thinking about how risk emerges in this discourse, we see a prioritization of risk. So primarily a risk to the fetus, that's the dominant construction. So the majority of the written submissions focused on the risk to fetal development, not the risk of having ineffective seizure control or being made to switch medication. With an explicit discussion of risk, it implies a responsibility. So someone needs to respond to that warning of risk in a specific way. And actually, there wasn't really an explicit discussion of who was, who was responsible for this, but there is a removal of choice for both physicians and patients in the Valproate story. So patients have to submit to the pregnancy prevention program, and doctors have to sort of ensure adherence to it. So that's sort of the background of public discourse. And again, the Independent Medicals and Medical Devices Safety Review, as published in 2020, was the most recent sort of output of that public discussion. So one of the big outliers to the submissions were the Association of British Neurologists. And so I've got a quote here from a letter that was included in their submission in 2014. It says, treating epilepsy is a balance of risk versus benefit. And there are not infrequent situations where the benefit of Valproate outweighs the risk. Furthermore, current guidelines highlight the principles of informed decision-making and the rights of the patient in doing so. If followed, the MHRA guidance would deny female patients that right. So this really speaks to the central tenet of the empirical work that I'm trying to do, which is how do we manage patient choice and consent to treatment and acknowledgement of risk, and viewing patients as rights holders who can make their own decisions, no matter what outcome, with this very restrictive policy that mandates a specific interpretation of risk and a specific response to that risk. So based on the Association of British Neurologists being that outlier, I chose to do some semi-structured interviews with consultant neurologists. Again, this is really preliminary findings because I'm still doing my data collection. So in choosing to speak to them, I sort of want to see how doctors manage that tension between, on the one hand, ensuring patient choice, and on the other hand, ensuring adherence to the pregnancy prevention program. And so I've got this quote from Armstrong about how we build up medical knowledge through the experience and collective minds and practices of doctors. And I think this extends to legal, ethical and social knowledge as well about this matter. So my research questions that I embedded throughout my interview schedule sort of speak to how do physicians negotiate certainty, uncertainty, risk and fear? How do they balance complex ethical concerns for women's health, her autonomy and the health of her future child? And how do they manage these tensions between ensuring informed consent on one hand and implementing a pregnancy prevention program on the other? So I've only done 11 semi-structured interviews so far, hopefully going to do about 30. So far I've had a range of views, from being very hostile to these regulations that the MHRA brought in, and those being quite supportive of the regulatory change and speaking about the impacts this has had on their patients. I think it's worth noting that there's been a really high level of enthusiasm of people wanting to speak to me about this. So I don't know whether it's the recent news coverage of it, or it's just a really complex thing that people have to deal with on a daily basis. But I think that's reflected in the length and depth of the responses as well. Most interviews are lasting around an hour and a half, and that many neurologists are really quite emotional about this, that this is something that they have to deal with on a very regular basis. So in the next few slides, I've got a few that speak to understandings of risk. So far, the risk has been focused on the risk of uncontrolled epilepsy and the risk of ineffective medication due to this treatment of Valproate, and how under recognition of this risk to women has led to some inequality of healthcare. And then I'll speak to some of the early thematic findings that that have been quite interesting to me. So first I've got a quote here. This is HCP1, as I'll call them. So there's the horrible choice between their life and a possible future life of a baby, and the lack of education and opportunities for women who don't have their epilepsy adequately treated in their teenage years and in their 20s. Those are such important years. And if they spend their life seizing and on often triple therapy with big doses of other drugs, the drop in their opportunities for life are huge. And I don't think the impact of that has been quantified on their future children, let alone their own mental health and life. So although I think it's awful and I would absolutely avoid putting people of childbearing age on Valproate at all costs, actually not at all costs, because the cost of the alternative. So this physician went on to tell me about a patient who she inherited from a transition clinic, so going from childhood to adult services, who was 17 at the time that they met. So this patient was having myoclonic jerks and absent seizures every day, multiple times a day. Her tonic-clonic seizures were less frequent at first, but seemed to be getting worse and worse. And she was at high risk. She was at high risk of injury death. And in this physician's own words, just couldn't function, couldn't get a job, and was on triple therapy, which included a benzodiazepine, which is a highly sedative medication, and 2 other anticonvulsants at very high doses. And she was still having seizures. So when this physician switched this patient to Valproate, 500 milligrams twice daily of Valproate, she was completely controlled. So for this physician, the experience of this highly restrictive form of regulation because of the risk to a potential pregnancy was putting this patient's quality of life in jeopardy. So this physician went on to talk about, how long do you wait to ruin someone's life, in their own words, in such important teenage stage before you control them at their epilepsy, put them on Valproate. So they raised some really important questions. How much cost of not having them on Valproate do you endure, and they endure, before they get their epilepsy controlled? And what do we do about the fact that we have no knowledge about these other drugs? So the implications of having someone on triple therapy of really high doses, when that's sort of the accepted alternative to Valproate. So another physician raised similar concerns about the experiences of patients who are put on drugs other than Valproate because of the way Valproate is regulated. So this physician said, there's a lot of women out there who have suffered horrible seizures. As I said, humiliating seizures, injurious seizures, and SUDEP, so death from epilepsy, sudden death from epilepsy. People have maybe died of epilepsy who didn't need to because they could have been on a drug that really, really worked. And this huge dichotomy, the young guys, it's really unfair. I just get them on Valproate, whack it on, see you later, lad, you're going to be fine, don't worry about it. And you've got this huge difference. Looking after men is easy peasy because they're going to get better. With women, it's just, oh my goodness, here we go. And then speaking a bit later, this physician asks, did it need to be quite so patronizing? Did it need to be quite so didactic? They don't know. So just this sort of quite exacerbated at this regulation of Valproate and what it means for their patients. Because again, so this physician talks a lot about the health inequality with male counterparts who you would automatically put them on Valproate for a certain type of epilepsy. But because these patients are being treated as sort of pre-pregnant or potentially becoming pregnant, so again, like Kirsty and Natalie were saying earlier, this decision is based on their reproductive capacity rather than intention. So another physician talked about 3 levels of risk. So for this physician, they saw patient risk, clinician risk, and corporate risk. So as part of the interview, I asked, what does ethical practice look like to you in this context? And for this physician, they say it comes back to patient risk, clinician risk, and corporate risk. So the corporate risk, they cover it well by saying, oh, you just need to record it, i.e. the pregnancy prevention program, whether they're on Valproate, whether they're on contraception. It's nicely in bold, and that's covered. Clinician risk is very much about, well, what am I meant to be telling you in that situation? So what are the risks? And making sure you record it. And for this physician, that's their anxiety about whether that's being adequately recorded and documented. And then there's the patient risk, which is basically, what does the patient perceive to be their risks for them and any potential pregnancies, for example, and how are they perceiving it and how are they taking it on. So I just thought it was quite interesting that this physician, you know, while others have talked about risk to female patients, this one I thought was quite interesting in how they've laid out these different conceptions of risk. So in part of my interview, I show them this image, which is a picture of the current iteration of the Valproate box. So this is Epilim, and this is the current iteration post 2018 regulations. So what also I haven't put up on this slide is that there's a tearaway prevent card, which sort of goes through you have to be on contraception, you have to submit to regular pregnancy testing. You know, it reiterates some of this information here. And I asked physicians to comment on this image and sort of say, you know, well, what do you think of this? So I've got a couple of answers here. So first, some physicians have talked about the sort of toxic nature of Valproate and whether the risk is being communicated in terms of risk to potential pregnancy or just risk to women or people in general. So this person says, you know, warning for women and girls. It's not only saying that this is dangerous if you get pregnant, but it's saying it's bad for you to take if you're a woman or a girl. It also feels for me, if I was a patient seeing this, it feels almost like an emotional blackmail. You're prepared to risk your baby in order to be safe. What sort of person are you? Speaking specifically on the crossed out pregnant woman icon that was on the image, maybe it's meant to make people feel uncomfortable and not to like it. But I just think for those who maybe wanted to have children and decided not to because they're on Valproate, it must be quite hard to have that. I think the guilt issue, you know, it's something that men don't get if something goes wrong with a pregnancy. Women always blame themselves and what they've done, however completely illogical that is. Now, if it's logical, that must be even worse. And I think hearing the presentations we had this morning, it sort of feeds into that idea around, you know, complete risk elimination and perfecting these perfect conditions before you even start to think about conceiving, and what must that be like if you need a medication that actually jeopardizes pregnancy development. So we had a couple more different views on the packaging and how that risk is communicated. So another physician thought that, you know, it's a very complex and difficult message to put on a box with a tiny pop-up window. And actually for this physician, they thought the simple message is you should be under, especially if you're on this medication, you need to be under a specialist for your condition. So actually the physician and the specialist is the one who should be communicating that message rather than having it in such a crude way on a box. Another physician said they're conflicted because ultimately, particularly with a chronic condition like epilepsy, it does not do to patronize a patient, to tell them what they should feel or not feel in response to something. Ultimately, I would hope that my patients could move beyond that, and that if I can educate them properly, not just me, the team I work with and the websites and everything like that, and they're sensible, they could move beyond dramatic pictures and hopefully be rational. So again, sort of how we communicate those risks and whether or not this sort of box is helping with that. So I've got a couple more, bear with me. So another theme I'm looking at is tensions between consent and the pregnancy prevention programs. So I asked them, you know, do you see any possible tensions or compatibility issues? So for this physician, constantly, the amount of forms, so the risk acknowledgement forms that they have to fill out, I have to annotate them and say that they don't comply with the prevent program. But I'm not going to recommend stopping their Valproate. And actually, you can't force someone to have an implant or a coil, and you can't unsafely stop their Valproate and kill them. There'd be uproar. Another physician talked more about the practicalities of consent rather than the principle, which is what I think this first physician talked about in terms of, well, the regulation is mandating contraceptive use and you can't really force someone. So this second physician talks about the practicalities and basically sees consent as boiling down to the risk acknowledgement forms. So this addiction towards convenience. So this form can be very rapidly completed to a very low standard. You sign it, they sign it, nobody reads it. and you use it as a way to ensure that someone gets their prescription. So this physician said, I think the more familiar you are with the tool, the more likely you are to dismiss it. So for this physician, consenting then for Valproate use is just signing a form, and just sort of, it boils down to that, and whether, you know, you can sort of achieve valid informed consent in this way. This quote, I think, sums it up pretty nicely as well, which is, ironically, at the time when there's an emphasis on patient empowerment, on patient choice, we've moved away from that to imposing values coming from all of these other factors, imposing that all on women who might potentially take Valproate, and even girls as well. So as one of the last questions that I asked my interview participants, I asked them what they think the goals of this regulation is. And I've gotten a range of answers so far. So the first, at the end of the day, is it to make a community safer? I hope that is the goal. So we're seeing differences between what someone hopes the goal of regulation is to what they actually think it's achieving, which I think is quite an important distinction when asking for interpretation of this sort of regulation. So another physician said they thought it was to minimise preventable harm. And this physician, you can see, sort of fell over their words a little bit about trying to get it right in their mind. So I think minimise preventable harm, but I think with the focus mostly on the unborn child, and they probably didn't have an equal focus on the inevitable consequence of the potential harm to the mother. There's a focus on minimising preventable harm to the potential pregnancy. And then this last quote I put was from a physician who told me what they thought the goal should be, which is no unconsented or uninformed pregnancies on Valproate, not a goal of no pregnancies on Valproate altogether, which tends to be sort of the main messaging of the goal. And that's sort of what we've seen in the media depictions as well, that sort of outrage that we've still got X amount of women, X amount of pregnant women still being on Valproate. So some preliminary discussion. Again, really initial data collection is not complete, but I've had a spectrum of responses ranging from hostile to supportive of the changes. And I've seen a range of ideas about tension between consent and the pregnancy prevention programs, both in terms of tension in principle and tension in practice. And I thought it was quite interesting that I've only seen one physician who spoke explicitly about the choice to have an informed pregnancy whilst on Valproate. So sort of how we should be responding to these risks in the sort of pre-pregnancy stage when it comes to planning pregnancy. And yeah, I really look forward to finishing my data collection and pulling together some of these findings. So maybe in another year or so, I'll be back. But yeah, thank you so much.
Yes, just in case. So thank you very much for inviting me. I've enjoyed all the other talks, so I'm now looking forward to this contribution. So basically my plan for today is to tell you a little bit about the project, the RAP project, the background and what the project design is, then to talk about the survey data, have an initial discussion, and then tell you where to find out. So the RAP project is a collaboration between the University of Southampton and the CRRC at BPAS. Rachel said that you've seen too much of her. Here she is again. So the main team is me, Rachel, and also Rebecca Brion, who's in the audience. So it's funded by the Public Policy at Southampton New Things Fund. So this was some money that we were given by Public Policy at Southampton to fund some research that might influence public policy. And Rebecca and I, so Rachel and I, sorry, put together a proposal to try and gather midwives' views on the proposals to record and transfer information about pregnant alcohol use in pregnancy. So the background to this is that we've seen over many years the development of a new policy framework which has focused on alcohol consumption in pregnancy, particularly with the goal of preventing and diagnosing fetal alcohol spectrum disorder. We've already heard about that today in several talks. And we've seen an increasing number of policy documents which first will try to enforce mandatory alcohol screening as part of routine antenatal care, but also proposals for automatic transfer of the child's health record information about all alcohol consumption during pregnancy. So Rachel put together these notes about the different policies that we've seen. This all goes back to SIGN, the Scottish Intercollegiate Guidelines Network, in 2019, their guidance 156. So that's where this idea of abstinence-only advice and recording and potentially transferring data kind of springs from. And from that, we then see this cluster of similar kind of guidelines. So the NICE guidelines, Quality Standard on FESD, Public Health England's High Impact Area 4, and the Department of Health and Social Care. So we see this kind of initial guidance and then that being kind of replicated over and over in other areas. Now, one thing that we were particularly kind of interested in is the NICE Quality Standard Consultation. So the draft of the quality standard was first published in March 2020, and that's based in part on SIGN 156. But as everybody probably remembers, March 2020 was a difficult time. So they did have a second consultation in August to September 2020 to give people a chance to actually consult properly. And this was quite a consultation with a record high number of submissions. There were organisations such as the BMA, the British Medical Association, the Royal College of Obstetricians and Gynecologists, the Royal College of Midwives, the National Data Guardian, all of whom raised concerns, particularly about the lack of due consideration to the impact on women, and in particular about the way in which this proposal to transfer information automatically to the child's health records raised questions about privacy and confidentiality, which had not even been considered. One thing which I think is particularly striking is that in the original equality impact assessment, there was no consideration of the potential impact on women. So many of us responded to this consultation and changes were made. So they did, in fact, do a equality impact assessment, which considered that there might be women who might be affected by this. And they considered the issue of the transfer of information from the mother's health record to the child's health record. And they removed this aspect from the quality standard. However, while transfer of information has been removed from the NICE quality standard, it still currently remains in that kind of mother standard, SIGN 156, and there's no mention of the impact on midwifery, healthcare professionals, possible impacts of access to care in the equality impact assessment. So we think the RAP project is going to speak to a gap there. and a point of view that really needs to be taken into consideration. So our hope is to gather, it's a small project, to gather some information on midwives' views on these proposals to record and then transfer information about alcohol consumption as part of routine antenatal care. So, how did we plan to do this? Well, we decided we would use an anonymous online survey plus a small focus group. We had to pivot, however, because the focus group did not go very well. So we then decided that we would have focus group plus interviews to try and gather a larger number of viewpoints than what we got in the focus group. We completed the survey. We're still gathering the interview data, and we have preliminary findings from the survey data, but we haven't done a full analysis yet. The participants were qualified midwives working as midwives in the UK. So we really wanted to focus on midwives' views in the UK context. And our research questions, well, we wanted to know how midwives understood what the current practice is when it comes to alcohol screening in pregnancy. We wanted to find out what their views were about mandatory screening and about proposals to automatically transfer alcohol information to a child's health record. We were also particularly interested in finding out about potential impacts on the patient-healthcare professional relationship and potential impacts on the midwife's view of their own role. So those were our research questions. Okay, so 166 participants responded, but of these, only 159 confirmed that they were currently working as a qualified midwife inside the UK. After you answered that question, if you said no to that question, we weren't able to continue doing the survey. So don't worry, we don't have responses from those 7 people. After that, response rates to each question varied. So the figures that I'm going to give are going to refer to the percentage of those who answered each question. But we did have quite a few people answering all the questions. So our lowest response was 104 people. Most respondents were working in England. We had 3 from Wales, 20 from Scotland and 2 from Northern Ireland. And we had quite a spread of years of experience when it came to the question, how many years ago did you qualify as a midwife? So most common response was 6 to 10 years. But we had around a quarter who'd qualified 5 years ago or less, around 17% between 11 to 15 years ago, and just under 10%, 16 to 20 years ago, and 17% over 20 years ago. So we had a good spread of years of experience. So our key findings when it came to the quantitative bits of the survey were that 83% of respondents agreed or strongly agreed that recording alcohol is already part of routine antenatal care, and 97% were in favour of asking about alcohol consumption at the booking appointment. So the sense was this is something they're already doing, is asking at the booking appointment, and they're in favour of continuing to do that. But most didn't support asking questions about alcohol use at every appointment. So 55% said no, 36% said yes, and 86% said that screening for alcohol consumption in pregnancy requires consent. There was also quite significant results when it comes to concerns about negative effects on patients. So 83% thought that mandatory alcohol screening could lead to patients feeling judged. 87% thought that it could lead to guilt or shame. 64% thought it might undermine trust between a patient and their midwife, and 70% thought it could lead to patients disengaging with maternity services. And 94% cast doubt on the efficacy, on how well this would work, by saying that it's going to lead to patients underreporting their alcohol consumption. And we have similar but slightly higher figures when it comes to negative effects of the transfer of the information to the child's health record. So 88% thinking that this would lead to feeling judged, 90% thinking it's going to lead to guilt and shame, 79% who think that it's going to undermine trust, and 77% worrying that it might lead to disengaging with maternity services. And again, we have 94% thinking that it might lead to patients underreporting their alcohol consumption. Well, overall, 53% thought that there would be an overall negative impact on their role of a midwife of mandatory screening, and 52% thinking that transferable information is going to have an overall negative effect. We did find some what you might think of as contradictory findings. So a majority of respondents agreed or strongly agreed with statements like alcohol screening is justified on grounds of safety or improved FASD diagnosis, or the treatment and benefits that this would give to children. So we had around 2 out of 10 disagreeing or strongly disagreeing with these statements, but figures of around 67.77% who thought that the safety would justify routine screening, 68.07% thinking that the benefits to children would justify it. And about 6 out of 10 respondents agreeing or strongly agreeing with statements that mandatory transfer of alcohol from maternal records to children's health records is justified on grounds of benefits to children. And slightly under 3 out of 10 disagreeing or strongly disagreeing with these statements. But only 42% of respondents were comfortable or very comfortable recording alcohol consumption at every appointment. Only 32% supported automatic transfer of all and any alcohol consumption. And most, I've already given you the figures, that most respondents considered that mandatory alcohol screening, transfer of information could have negative effects on patients, and almost all thought it could lead to underreporting of alcohol consumption. So how should we interpret these apparently contradictory findings? I mean, one thing that we might assume is that when we talk about routine screening, what they are saying that is justified is not routine screening asking at every appointment, but asking at one appointment, because there did seem to be support for one appointment, but not support for every appointment. Also that mandatory might not mean automatic. So there was support for mandatory screening, but not for automatic screening when we separated those two. Well, when we asked about automatic screening, that was not favoured, but mandatory screening was favoured when it was coupled with the potential justifications. It's hard to square the negative effects with this overall judgment that it's justified. But what could be happening here is we asked about the justification first, and then we asked them to think about potential negative effects. Maybe they didn't think about the negative effects until they were asked about them. So we kind of wish that we'd asked them whether they thought it was overall justified after having asked about the negative effects on patients. Or it could be that they do think overall that some kind of routine screening is justified, but there are significant concerns that need to be considered. We also included 2 free text boxes in our survey. We had 90 comments for analysis. The 2 free text boxes asked us, so the first one said, using this text box, please tell us how, if at all, mandatory alcohol screening and subsequent transferal of information to a child's health record would impact how you view your role as a midwife and why. And the second free text box just said, please enter any other comments. So we had 101 comments that were submitted. 70 people responded to the first free text question and 31 to the others. But there were 6 that were excluded from the first question and 5 from the other comments. So we had some interesting responses to the first one, which was copied text from a paper on the internet. Any other comments were just things like not applicable, none, see above comment. So we had 90 comments which we thought were worth analysing, and most of them did raise concerns about the proposals, but the comments did, I mean, I originally suggested, shall we see, what proportion are kind of broadly in favour, what proportion are rejecting the proposals. And we decided that actually wasn't a good way to analyse them because the comments contained a lot of nuance. And in fact, some survey responses seem to capture a kind of competing tension between, or some of the competing tensions that accompany this topic of alcohol and pregnancy from the point of view of a midwife. We identified 4 key themes in our initial analysis: consent and rights, women's rights versus children's rights, midwifery as a public health role, barriers to relationships, and practical issues. And I want to just stress again that this is our very preliminary analysis. So when it came to consent and rights, women's versus children's rights, we saw a sort of, some of the rights were focusing on women's rights, some thinking about the rights of the future child. So for example, the first comment I think means fetuses rather than neonates. The comment was, although neonatal well-being is a fundamental concern for midwives, neonates have no rights under UK law. I think that we've taken it that they meant fetuses have no rights under UK law. Other comments said, I don't believe it's required at every appointment and believe transfer of information would benefit the child, but it's the mother's information, therefore consent should be sought. Similarly, automatic transfer of records to babies' records is a complete breach of privacy and confidentiality, and I am against it. On the other hand, another commenter said, I think women would not always be truthful if you were taking their word only. I think there are many children born with FAS, and I think the child has a right to this information to be available. So rights picked up on both the women's rights and the children's rights. Others focused on the midwife's role, seeing midwifery as a kind of public health role. So FASD is so disruptive and early diagnosis is so helpful. I think this is part of the public health professional role of the midwife. I don't feel including mandatory screening would impact the relationship. I see it as another part of the midwife's role to promote a healthy pregnancy in all aspects. It's a public health screen to try to protect unborns from FASD and or other adverse outcomes. However, some people, this final comment says, similarly to CO screening, I don't think it would change many women's habits, nor necessarily change how much influence I can have on their decisions and actions. I can give advice, it's for them to decide what to do with it. So that's a slightly different understanding of the public health role of the midwife, one which emphasizes the mother's, also the pregnant person's informed choice. The third theme was barriers to relationships. This came up a lot, probably as you would expect, given the concerns that were raised in the quantitative questions. I think there's a real possibility that the relationship between a midwife and a woman will deteriorate if the woman perceives the relationship to be one of surveillance rather than support. Mandatory alcohol screening would increase the chances of women feeling that their actions and behaviours are being monitored, and this may increase feelings of guilt or shame. I feel it actually may isolate women more from their midwives. The next one, talking about putting a huge barrier up between the midwife and the pregnant person. However, not all of the comments thought that there would be problems with the relationship. So a couple of comments raised the point that it's part of the midwife's role to be able to have these kinds of conversations without being judgmental. So one comment said, as a midwife, if I couldn't have this conversation without being judgmental, I would be in the wrong profession. Other comments raised practical issues. So the problem that midwives already have a lot to do in these antenatal appointments, midwives who already have a lot to record, others about it being a fine line to tread in building trusting relationships, and adding alcohol into the mix is another pressure point for women to feel judged. Another one of the intrusive questions regarding women's lives, and the way in which this conflicts with building a relationship. However, some comments suggested that this is actually going to be practically helpful because without screening or formalized recording, many midwives would unfortunately also fail to give information in a meaningful way. A lot of midwives also commented that they thought there were going to be problems with the proposals. So, for example, one said, it may discourage occasional alcohol drinking in pregnancy, but I feel that those who participate in heavier intake or riskier drinking may simply not disclose information about how much they truly drink. Okay, so we think that one thing these findings suggest is that the practice of asking about alcohol consumption in pregnancy is already it's part of routine maternity care already. It's pretty well embedded. There are concerns about potential implications of extending these discussions to, first of all, to include the transfer of data, and secondly, to require discussion at every contact. So the overall feeling seems to be, we currently ask at booking, that's fine, but more would be too much. It seemed as if many of the midwives that were responding, they understand the kind of proposed justifications, they see that there are perceived benefits, but they still have concerns about the execution of these proposals. In these findings, we can see both an acceptance of cultural expectations about how pregnant people should behave. So generally an acceptance that women should not be drinking alcohol during pregnancy. but also concerns about formalising those expectations and requiring midwives to take on this monitoring role. So one respondent said it might feel as though this information is being used to determine their fitness for motherhood. I also we had one comment that we wanted to note, which raised the question of the racial considerations and how these, in what we find ourselves concerned about. So the suggestion here is that we're tackling a white cultural tradition that's potential harmful for babies. So this is taking up research space in order to protect the rights of white women. So one commentator did raise this question of, you know, what do we protest against? Where do we draw our lines? Which of course doesn't undermine the importance of considering these proposals, but it is definitely worth bearing in mind. Okay, so to find out more, you can look at our project website, or you can email any of us. And now I will sit down.
Okay. Questions, comments?
Thanks. Two really great papers. The question is going to go back to part of the conversation we were having last time about the concept of risk, because although this is framed as risk, I'm thinking, I mean, particularly in relation to your paper, Rachel, but I think it does also touch on what you've been talking about, Fiona. If it was a real risk balance, as I think one of your participants said, it would be, okay, right, if you take this drug, there is X percentage that your child will be born with this abnormality. If you don't take this drug, there's X percentage you're going to die. So would you like to now make an informed decision? But it doesn't seem to ever be presented like that, in the same way as when doctors go into women who are labouring and say, right, we need to do forceps. It's not if we use forceps, there's a 3, or if we don't use forceps, there's a 3% chance your baby's going to be like brain damage. But if we do use forceps, there's a 40% chance you're going to get a 3rd degree tear. Like, they don't go in like that. They're like, we have to do this because we know what's better. And this, I think there's something in that of, as Pam was saying earlier, it's not actually, it's not risk, is it? It's sin, and it's that idea. And I'm not sure this is a very well formulated question, but hopefully you get what I'm trying to get.
Yeah. I think with what I'm learning about Valproate very much is that, well, especially in the minds of some of my participants, is that we've seen almost, some people would say it's almost like an overcorrection based on the historic failings. So I think with Valproate, that's a very important part of this current regulation, is that, you know, since it was first licensed for use in 73, there has been this sort of emerging literature that points to the harms if taken during pregnancy. And yet, I think a lot of people point to this paternalistic time in medicine where physicians perhaps didn't warn women who may be pregnant about this risk, because for them, that decision about which risk is more important, controlling epilepsy, was deemed more important. So what we're seeing now is this sort of, I mean, I personally, again, my opinion, it's like a transformation of what informed choice about risk means in this sense. So a lot of the patient advocacy groups that have been pushing for the change of regulation see a pregnancy prevention program and having a more formalized regulation of this medication as enforcing informed choice. For me, it's sort of, it's a bit jarring, because I don't think there's a choice in that. It's saying, I think the underlying message is, well, if anyone was to make a choice, you'd obviously avoid taking this substance that causes a real risk to a developing fetus. So that choice is just sort of implicit in that. Sorry, I'm not articulating very well either, but I think, yeah, rather than having a balanced message and letting, at this point in time, letting people make their decisions about their individual goals of healthcare and, you know, what medication may be most suitable at any given point in time, there is just this like underlying current that, well, if no one would reasonably make the choice to have a pregnancy on Valproate, and that's sort of what's permeated that
It feels more
message.
like enforced compliance that's been presented
Yeah.
as risk management.
And sort of saying, well, this is, yeah, I've characterized it as an overcorrection because it's sort of combating this history where people weren't told that this could cause harm. And so for those that are really pushing for the regulation change, like, I can't imagine those experiences, and they're really important experiences, but does it mean that the drug now needs to be regulated in this way when actually we've only used pregnancy prevention programs before for acute periods of time? So with acne medication, for example, or when they reintroduced thalidomide, it was used for leprosy or sort of end stage cancer treatment. So those are periods in time where people are probably not going to plan a pregnancy in that time. But we're talking about a chronic condition like epilepsy that sort of lasts forever, and people could be on that medication for decades and decades and decades. And are you saying then throughout your entire period of time while being on that medication, this is the only way to respond to that risk, which is just don't take it? So I think that's an important dimension to it as well. So a bit rambly.
Yeah, so just following up on this, I just wondered whether abortion came up in this discussion topic as well, because obviously you don't have to make a decision right one way or another prior to pregnancy. You can make a decision after you found out you were pregnant as to whether the risks are too high for this particular pregnancy and you could opt for abortion. Is this anywhere in the discussion?
So it came up very small amounts. So I think with 1 or 2 participants actually spoke about the choice to terminate a pregnancy when contraception wasn't, you know, desired by patients. And sort of, what's really interesting when looking at the design of pregnancy prevention programs and when it's been used historically, so abstinence at one point in time in the 70s was thought of, this was in the States, as a form of contraception that you could, you know, have annotated on a sheet. Now, you know, you can't even use the pill because it's not the same as a LARC. So I think it's interesting about what is acceptable and what is not, and the idea that abortion may be an option in dealing with an unplanned or an unwanted pregnancy at any given time because you don't want to be on a long-acting method is not one that really enters that debate or that discussion in a formalized way.
Such an absence.
Is there anything around legality to this? Like, has there been legal challenges to the pregnancy prevention? When I originally read through documents, it sounded very actually it just sounds like and sign as well.
Yeah, so I mean, in terms of the legality of this regulation, so it does a couple of things for physicians. So if you want to prescribe and your patient doesn't meet the criteria of the pregnancy prevention program, then they're essentially prescribing off license, which poses its own thing for physicians. I mean, I'm not a medical professional, so maybe a medical professional might want to speak about what it means to prescribe off license in that situation. And I think that what I'm finding interesting about the range of responses is I've had some participants viewing this regulation as a tool that they can use to strong arm is a phrase that was used in an interview, so sort of strong arming their patients into taking contraception or to coming off Valproate finally or something like that. So I think the legality question is interesting because it's also how medical professionals interpret it and how they sort of apply it in that individual situation. It's interesting to think about.
Sign as well, I think it's
So this, if Rachel, correct me if I'm wrong, but my understanding is that it's in sign, this is still, it's like, this is where we want to go to. Right. It's not, this is, that we're going to, we've not, it's going to be implemented. It's, you know, this is where we should be, what we should be aiming for. Is that right?
I mean, what's also interesting about the notion of transferring information is that some CCGs and some trusts have been doing, I don't know if we use CCGs anymore as the right terminology, they've been doing it already. So in areas like Manchester, for example, they've been transferring data since 2016, and that's sort of been piloted as good practice, and Manchester is held up in a lot of these policy documents as like a good practice point. Whether or not anyone's actually legally challenged what's happening there is different. And you've got, you know, the UK National Screening Committee, for example, that has routinely rejected this type of alcohol screening on a population level, but they're not able to sort of challenge individual practice, which then I guess raises questions of what can the UK National Screening Committee do in this situation. Well, there's been a nice news article about it. Yeah, so there was a news article on like a local Manchester newspaper, you know, like this is the first trust that's been doing this, and sort of like, again, held up as a good practice point in the aim to complete elimination of any alcohol exposed pregnancies.
This is the same one that has the health promotion campaign trimester as part of what they do that Claire was mentioning earlier.
Yeah, interesting.
Patricia?
Just wanted to add to what Rachel was saying earlier about prevention programs and miscarriage abortion. Recently been contacted through one of our
Thank you.
about whether we have a system to fast track people who have come for an abortion where we into their GP or some sort of consultation. So it's almost like, you know, abortion is always the least best option, right? Everybody acknowledges it's there, but it's really not. Right? So almost to an unwanted pregnancy. It's as though you've fallen off the wagon, right? You've fallen off the wagon, had your abortion. Now we need to make sure that you're back up appropriate services. And I'm sure that the concern is that someone will not
just sort of getting the data without having the discussion with the person, and that sort of attempt to sort of avoid whatever through that kind of impersonal connection. I don't know if that makes sense, but I just thought it was just very interesting that, with the exception of one midwife who basically said, well, if I didn't judge, I wouldn't be doing my job. You've got others who are very worried, but they don't actually get, they find it really awkward to have these discussions. But at the same time, they think they ought to know, and they think they've got a right to know. And that they seem to think it's very important.
So the final midwife, so she was saying that if she couldn't have the discussion without coming across as judgmental, she wouldn't be doing her job. So what I think her point of view was that actually it's part of the role of a midwife to be able to have these discussions in a non-judgmental way. So I think that was definitely an element, that this is part of our job to have these discussions. And there was some people who seemed to see the screening as as something that would make midwives talk. So, but you're right, there is this distinction between, is the important thing the information, or is the important thing, so is the important thing getting the data from the women, or is the important thing getting the information to the women? And those did get, so there was certainly in the public health role, there were many people who seemed to be in favour of the proposals because they see it as their public health duty to inform the women. But actually that can be separated from the question of what information should be taken, what data should you be collecting from the women.
I think it's not surprising that there's confusion's the right word, ambiguity around all of this, because that's exactly one of the things that's kind of worked itself through in the differences between the draft NICE quality standard and the end result. So if you look at the draft, the only thing that is interested in is getting the information on the basis that then can give the child the information that they have the right to know. And this is the position of the self-described UK FASD community, who are disappointed that the mandatory transfer of information didn't end up in the final quality standard, because their case is that what matters more than anything is that piece of information is made available to a child who may be diagnosed with FASD, because without it, you can't have the diagnosis. So that was the only thing they're interested. The quality standard, as it was published, has a different sort of language. So actually, what's in it on this on this question much more emphasises the importance of midwives having personalised conversations with women, and so it emphasises that interaction more than just getting the information. So it, and I think that there was, all credit to the campaign from BPAS and Rachel and everybody else that was involved in this, because they, there is a difference between the draft quality standard and the one that has ended up. But I think it also explains why there is some level of ambiguity in your responses, because the whole thing has been a fairly fraught process, hasn't it? Yes, Patricia and then Maclean.
Just a question. I mean, do you think it's because they're just prioritizing the well-being of the fetus out over the woman? And this is why they're willing to sacrifice the relationship with the patient in order to protect the baby. I mean, nobody seems to be talking about the fact that there may be women who are drinking in pregnancy who would like to stop drinking because of their own well-being, and that seems to be completely missing from the discussion.
The policy process, though, I mean, one of the things that's important about what's gone on, which I think is really striking is that the policy makers, the people that have written these documents at NICE, at the DHSC, at Public Health England, have been interacting with one field of opinion only, which is the UK FASD community, and there is a remarkable level of policy capture, and that has only been interrupted by an alternative point of view being brought into this process from the outside. And it's one of the things that I think is remarkable about this process, is that you can have the development of a policy framework which includes within it a pretty fundamental readjustment of midwifery practice and the way pregnant women are treated within the service, without any input from representatives of women's health and the world of reproductive health. You know, they were entirely absent from this process.
I think it's worth pointing out this for the people who don't know, it's because the campaign groups around fetal alcohol section are almost all adopted parents. So that's, if you were kind of wondering why that they didn't know, that is because that's the main constituent, and this is why the emphasis is on passing the information.
Yeah, sorry, who, yes.
Okay, sorry. Yeah, and I just want to clarify, I can't understand if whether you embrace that there is an objective knowledge and objective data like concerning alcohol or this medicine. I think that in Israel you are allowed to have medicine when you have got epilepsy, but it's just that you are under supervision of your doctor and things like that. And then I think that if you don't accept that there is objective knowledge, and knowledge is even data concerning alcohol consuming or any other thing, that it's not, that it's always contextual. So if it is contextual, so then you would ask from which point of view do you look at this data? And I think that the social discourse is that you are looking from the child's point of view, because the mother is only the vehicle for the child's well-being. But because this is the body of the mother, so if we are looking at this from the mother's point of view, so you also take into account the child's point of view, but you also take into account the mother's point of view. And I think that your case of the epilepsy is giving us an opportunity to look at an extreme case where the mother's point of view must be taken into account. And that makes it interesting because you don't have many cases like this.
Yeah, I mean, I think with the case with the pregnancy prevention program and epilepsy and medication for epilepsy is that the PREVENT program is for basically girls from the moment they start their periods all the way through until menopause, basically. So it's that consistent treatment of what Kirsty, I think, said pre-pregnant, that sort of pre-pregnant state throughout that entire adult life, on the basis that this person might then have a baby and then have an exposed baby because of that medication. So I think we see the dangers of sort of substance use, whether it is medication or something like alcohol, sort of permeating the way we think about women of childbearing or reproductive age more widely. And that's why I think for me, the point of view of the woman and that sort of voice and, you know, what it means to have to make those choices between effective seizure control and then being treated as pre-pregnant for that entire adult experience is what's
enormous questions, and also for parents of girls. So I mean, I've got a son who has been severely epileptic, who's been on sodium valproate since he was 10. And without it, he would be having daily seizures and completely incapable of attending school or doing that. And to be honest, it's been bad enough having him on Valproate, but at least it stopped the seizures. I mean, if he had been my daughter from the age of 12, I would then have to be having her on a, which raises enormous issues about what would you do? You know, how would you think about this? Which obviously is a great idea for a follow-on. Natalie, last comment and then we'll move on.
In general practice, alcohol screening is in order.
Yeah.
Because in pregnancy, and risk. I just wanted to say also, I wondered what midwife's understanding of screening was in antenatal. Because you talked a lot about midwives having conversations. That's not the same as a validated like audits. And wondered what was their understanding, and it seems like to me quite a high proportion of people that would be willing to do that every appointment. I wondered, are they just talking about an appointment or about?
I think that the guidance itself does not have. I mean, there isn't a validated screening tool that would work with the guidance, because it's not.
So I think what was really interesting about the policy background as well is that so in SIGN, for example, they do mention validated screening tools, but it says it should be asked at, that they muddle themselves because they say dose, frequency, pattern of drinking should all be recorded at every appointment, but that goes beyond what Audit C would tell you as a validated screening tool. So the policy itself is a bit muddled, but in terms of what we asked, I mean, I don't have the questions from the survey in front of me.
So we talked about there were questions which were related to the proposals. So does this justify the proposal to have screening? And then there was questions which asked about, do you ask about alcohol at this? And they said that they asked about alcohol at every, most of them said they did it at booking. They said that routine screening is already part of antenatal care. So that suggests to me that they're not understanding it as, they are understanding just asking about it as counting as screening.
Yeah.
That there wasn't a kind of, I think that they just asking about it is being understood as screening, and there isn't a great deal of understanding about the difference between just asking about something and using a validated screening tool. Although there was one comment which did say which tools, which screening program will be used. So at least one midwife is aware of these differences.
Very quickly, two booking appointments in the time. It was approved. And there's no opportunities in the route. So yeah, that's still the it's the idea that there's no judgment. It's maybe subtle, but it does.
I think it is one of the remarkable things about this whole area which we need to find a way of having some further discussions about, is the whole concept screening and the ill-defined, promiscuous way in which it's discussed within this area in a way that would be completely unacceptable in other areas of health. And you know, it is really one of the interesting things about the National Screening Committee. As it happens, the same issue has pertained around screening for postnatal depression. you know, the National Screening Committee never agreed with the Edinburgh Postnatal Depression Scale, but it's been widely used and adopted. And it's almost like the whole, everything to do with women and pregnancy, it's sort of in a box of its own, with the way in which these what's called screening, the way it works, and it seems to be completely interchangeable across a whole load of different things, and then nobody ever really knows what they're talking about or what happens. We're going to have to stop now, I'm really sorry, because we need to get Edmé on.